Well, Celestina, thank you for joining us from Spokane. We appreciate it, you joining us today.
Thanks for having me on.
So when COVID broke out and there was much made of the fact that the disparities, particularly in communities of color, were really being revealed. But the truth is, those disparities have always been there when it comes to healthcare inequities. So it really wasn't anything new. But yet we seem to not be addressing this issue, right?
Right. Yeah. I mean, I think when it came out, even within the state of Washington, where we have great access to healthcare, we're doing a lot here, in terms of getting everybody having access to healthcare. We still saw really big disparities with COVID, folks getting COVID, hospitalizations, folks dying from COVID here in our state. We saw really large racial and ethnic disparities, just even across our state and certainly nationwide. Wasn't a surprise to a lot of people that study health disparities and, racial inequality, because it was just these disparities exacerbated other existing disparities that we knew of.
So, Matt, you have kind of a story that you heard regarding this issue, particularly when it comes to health inequities, and share that with us.
Well, okay. So I was working for the mayor and just a few months ago, and we were out, and he said, "Oh, by the way, I have to stop at the UW hospital to visit a patient." And I said, "Well, okay, that's great." And he said, "Well, the reason I'm stopping by, a friend asked me to visit his mother, and his mother is African American. And he said, the reason I'm doing it is because they feel if the mayor shows up, shows interest in his mom, that the staff and the hospital will take better care." He said, "And I want to make sure that you know that the UW isn't about that." But he said, in the community, there is that belief. And I got to thinking about it, and I was like, that's true. I mean, because everything says, but I don't think of it because I'm Asian and a lot of the healthcare professionals are Asian. So I feel very comfortable in those settings. But I can imagine if you're Black or Latino and you're in those situations, it is somewhat hostile.
Yeah, I think that's a great point, Matt. I think that's a fascinating story because I think that people of color, we often try to think of ways to make sure that we're treated the same, getting the same access to healthcare, the same quality of care. What can we do? How can we make sure, knowing that we might have personal experiences where we were treated pretty poorly, or with our grandparents or parents in a clinic, doctor's office, or even just by, the front office when you check in. There might be issues of just everyday discrimination in your life where that's going to translate also into the healthcare that you get.
Yeah. I mean, it's almost like, okay, it's enough to code switch in your real life, but then you have to code switch in a medical setting. And I know in Seattle, there's translation services and everything else like that. But if you're not fluent in the language, and medical language is difficult, people have to get lost in that.
Yeah. And I think too, even above and beyond, translational services, or not even speaking the language. Gosh, when you think of, folks coming from other countries, refugees, things like that, the uphill battle that they're going to have to fight just to, be treated and be seen is so difficult. But I think even for folks where English is your first language or a close second, I think, we know that, there's a good chance that you're going to be treated differently, either just because no one looks like you, in the medical setting, or, you might not have access to the resources. You might not live anywhere near the big hospital or the hospital that has the expertise. If you're coming from a rural community, we know there's big disparities. Definitely for communities of color, there's a lack of trust. Often there's been some, the medical history, research history, it's not a great history with communities of color, with people of color. And so all of that plays into it.
Yeah, I noticed when they started giving out the vaccines, one of the questions that astonished me was, do you have insurance? And that wasn't supposed to be a factor. And I asked them, like, why do you have to show an insurance card if you don't need it? Oh, we just do. Well, can you imagine an immigrant or an undocumented walking up there and having to show those kinds of papers? That's immediate disincentive.
Yeah, absolutely. I think that a lot of states, including our own State Department of Health, really learned the rollout of the vaccine. Having to have access to the internet to sign up was, really the only way that you were going to do it. Having to navigate some pretty darn tricky questions where I have a PhD, my mom's a nurse, and we were talking to one another, trying to figure out, what is the ID that they're talking about? Which insurance card, what about Medicaid? What about this? What about that? Now I have to go into a patient portal, but I'm not seen at that clinic or that. There were so many barriers there. And it was really, I think that's just another example of when you have privileges, you're able to navigate a really tricky situation or, tricky system. And when you don't have those privileges, it's really easy to just say, gosh, this is not for me.
How do we change that? Or how can you change that?
Yeah, gosh, that's probably the $1 trillion question here.
Literally.
Yeah. I think as a researcher, so I'm at Washington State University Health Sciences, Spokane, and we have a long history of researching health disparities and documenting it and demonstrating it and showing even the differences across our state. So mortality differences across Eastern and Western Washington exist. So not being near, larger hospitals, not having that access, folks in rural communities. We know the disparities in communities of color on top of that. Then when you add on a layer of being in a rural community, your chances of survival, your life expectancy differs even just across our state. And so above and beyond research, also here at WSU within our College of Medicine, they're looking at the curriculum starting early in medical school, looking at the curriculum, looking at skin tone and skin color to see when we even start training our physicians. And certainly this applies to, nursing and pharmacy and every healthcare, provider. What are we showing them as a patient, as a typical patient? In curriculum, it's white people. Seeing skin colors, of different skin tones is rare. We need to do a better job at that. I think also we do a whole lot of framing within research and then also within healthcare curriculum where we talk about differences in race and ethnicity. And we just leave it at that. We'll say, if you're Latino or Black, BIPOC, you have a higher risk of dying from cancer, let's just say, or this or that. And then we just end the discussion. And we don't talk about why that is. And now, finally, we're being pushed as academics, as researchers, as healthcare providers to acknowledge what the reason is. And the reason very rarely has anything to do with genetics and almost is always just simply because of racism, how people are treated, systemic racism, institutional racism, everyday racism and discrimination. That's why there's the differences exist there. So I think the first step, Enrique, is naming it, is calling it what it is, and not just ending at, there's racial differences. We know that, or, and the same can be applied for gender differences too, Right. And so I think identifying that and working really hard, certainly not starting in medical school, but starting in preschool and kindergarten and everything else, and really just doing our work with, anti-racism work so that it will permeate every institution, including, healthcare institutions.
That's so weird. That is, I know what you just said, but it's still chilling to hear it.
Yeah.
Because it kind of means that racism is sort of baked into the medical profession.
Yeah.
Which is amazing.
Yeah. I would argue probably into every profession. Higher ed. I love higher ed. I'm a huge advocate for it, but we know it, it has roots in racism and in privilege and things like that. Washington State University, we're a land grant institution, and we take that very seriously. We are here to serve every resident in the state of Washington. And on the health sciences, we're here to help improve the health and well-being of every resident in the state of Washington. every resident, not just the folks that have the privileges, that have the money to come to a hospital, that have the money to come to a university, but every resident. And we have to do a better job at that.
You know, I can remember as a young man going to doctor's appointments with my parents who were Spanish speaking. And one time my father, who he was in really bad pain, and we took him into a hospital setting. And the doctor came in. Well, the first thing they did is that they asked us who's paying. That was the first thing. Second thing they said was, the doctor walked in and he starts like his delivery increased the volume significantly. And I got irritated and I said, my dad is not deaf and he does understand English. So, he's in pain. That's what's going on here. But I remember being so irritated about that. So I guess what I'm wondering is that the university now has a medical school, you have a nursing program. What are you doing with the students that are going to, become our nurses and doctors on their bedside manner, and to tell them, they're people, you treat them as people and realize that they're just like, anybody else that comes in.
Yeah, that's a great question. Well, it used to be okay to have that one diversity class, right? Every student had to take, you had one, and it was supposed to cover all the cultures, and then you're just out there as an expert. Now we know that is not nearly enough. And I think a great first step that's happening in our colleges here is threading a diversity curriculum throughout all of the courses. It's not just a one-off course, it's threaded throughout the entire curriculum, so that it is based on treating all people. Our college here, College of Medicine, is really focused on, retaining their graduates and having physicians here in Washington and Eastern Washington, and really being able to serve the local communities here. So we do have that emphasis. We also have the Native American Health Sciences here on our campus, where we actually have a clinical room, a simulation clinical room, where we do have traditional healers, physicians that are Indigenous come to teach about how to care for Indigenous patients. We need to expand that. We need to really focus on all of our residents here in our state, but we do need to have specialized education, and it needs to be threaded throughout the entire curriculum.
Well, it's going to take a while for that to thread through the system. Mm-hmm. What would you tell a person of color entering, as a patient, entering, a facility or treatment, because you start off with a huge power differential that even if you're a white person is daunting. So how does a person of color advocate for themselves without appearing angry or not understanding the language or defiant? I mean, what can patients do to make themselves, I don't know,
empowered, really
empowered
to be able to advocate for themselves?
Yeah, gosh, that's such a great question. My first reaction is, trust your gut. If you think you're being treated unfairly, you probably are, and to seek others, to seek out others, to seek out other people in your community that can maybe help to get you connected with a clinic or a physician or a hospital where they've had positive experiences. I think that's what I would tell a family member, my mom, my dad, my brothers, myself. If I feel like I'm treated poorly, then I need to go somewhere else, especially if I think that it's because I'm Latina. But I also think too that we have community resources often. Sometimes we have resource deserts, rural communities, things like that. But we do have community resources at local public health districts that can help. I don't think that a lot of people know about a lot of the resources that are out there that can potentially help them navigate systems. The systems that we have are so complex. But anytime we can put out the word for wraparound services or phone numbers that they can call. Just knowing that there's translation services, that they don't have to be local there. They can call a number and get any language you need, and you can talk to someone on the phone. Just knowing that there are those resources there. But really, I think it comes down to what we've always done. We trust our friends and family and community members who look like us, who have our experiences, and try to find others that we feel safe with.
So let's talk about the elephant in the room, or actually maybe it's one of the elephants in the country. And that has to do with what's been happening at the Supreme Court level, and in particular, Roe versus Wade. I take it the university has come out with some type of statement regarding this, and what have they said?
Yeah. So WSU put out a statement from the president and provost, really highlighting the gender inequity and inequalities that this highlights, that continues to exacerbate. Really wanting to care for the health and well-being of the entire Cougar family, and prioritizing that, continuing to prioritize that. Concern for student, staff, faculty, mental health, as everyone's trying to deal with this. A lot of emotions around this. Our College of Medicine put out a great statement, really highlighting that the overturning of Roe v. Wade, really goes against the principles, the founding principles of medicine, the College of Medicine. And when you restrict access to healthcare, that is not what our College of Medicine was founded upon. Concern for patient safety, concern for the best quality medical education and training that our students would get, and really renewed and continued commitment to the community, to staff, faculty, students in the College of Medicine, knowing that they'll do everything that they can to ensure patient safety, the full continuum of care for maternal and reproductive health. Really aligned, the College of Medicine and university really aligned with the major national healthcare organizations that put out statements, really, denouncing the opinion just based on safety, patient suffering, lack of healthcare, physicians and nurses being legally mandated to behave in a certain way that does not align with evidence-based clinical guidelines for healthcare. That's a really big deal.
But they don't seem to care. The Republicans that push this through don't care. So, all the good intentions in the world, what's it going to look like? What is the healthcare system? How can they respond? Is it going to be sort of a patchwork of places that do provide, abortions where places don't? But what if states decide they're going to charge with a crime a state that assists one of their citizens? It's just going to be nuts. And none of this is about women's health, of course, right? It really isn't.
I think so on the legal side, I don't know what that's going to look like. I don't know if legal experts know what that's going to look like just yet. I know that our governor, along with, Oregon and California, the governors have really come out publicly to say that we will continue to have access to full healthcare here in our states. I don't know if that means that folks are going to be seeking healthcare here. I would think that, patients needing certain services, would need to travel, things like that. I don't know how that's going to change the landscape of healthcare in other states. I'm hoping that it doesn't change much in Washington, but I really don't know.
But it's going to be such a far-reaching effect with all of this, because yes, there was the legal decision, and I guess the moral implications of all of that, whether you support it or not. But it's the healthcare, that the fallout every which way, it seems, and every day we seem to hear something new. I guess for communities of color and women of color, what do you see the impact?
Yeah. It'll be yet another disparity, right? Like yet an exacerbating of disparities. I think that those that have higher incomes and more privileges will have access to more healthcare always. And so when we look at communities of color, when we look at low income, rural, access to healthcare, access to safe healthcare, access to all healthcare services just continues to be limited. Nationwide, higher education is also a concern too, because this disproportionately impacts female students. And we know that women of lower income, with lower incomes, with lower socioeconomic status backgrounds, are more likely to leave education to care for a child. So women first, disproportionately impacted, lower income women even more impacted, will even be more likely to step out of their education trajectory to care for a child. And that of course impacts financial attainment and everything else. So there is a concern about that too. Mental health, American Psychological Association has put out, statement, American Medical Association as well, looking at stress, depression, anxiety, decreased quality of life, all of these things, decreased life satisfaction when not having access to full spectrum of reproductive services. When you think of victims of rape and incest, and even with these exclusionary clauses, they are known to be very difficult to navigate. So PTSD, there'll probably be an increase in that. They're expecting to be a lot of, psychological impact as well.
Systemically, a lot of medical institutions are religious-based organizations that run them. Luckily, the Ellison School and UW Medical, are state institutions.
Mm-hmm.
But some of these are private nonprofit organizations that have religious affiliations, and there is a big religious quotient to the whole abortion issue. Do you hear anything about what may take place at those types of institutions?
Oh, that's a good question. I haven't. I certainly looked at some statements. I was looking to see what some of other universities were putting out. I think that if it's this is just a guess here. I think if it's a religious-based, university, I think they already had restrictions in place within their curriculum, not to cover certain things that didn't align with their religious affiliation. So I don't think that would change within the private institutions, only because I think that restriction was already in place.
Mm-hmm.
Would you classify the healthcare inequities in our country a crisis?
Yes, absolutely. Yes.
And I guess it seems to me this is going to cost the country. It's already costing us so much money. How can it not cost us more? As we know, these inequities already exist. And then with other issues pounding or adding to the whole equation, which is, not a pretty picture.
Right.
Yeah.
Mm-hmm. Yeah. Racism as a whole is a healthcare crisis because of the impact it has, the health disparities within any disease, any illness, any hospitalization, even preventative care. We see huge inequities. And so, yes, if even just on a financial front, zero altruism, in doing the right thing aside, just on the financial front, yes, a huge crisis.
One of the things that I know that you've studied is the opioid addiction problem.
Mm-hmm.
Again, there's racism in that. I read a Washington Post report where they said there's a drug, and you know how to pronounce it. I don't. That starts with a B.
Buprenorphine.
That is used in treating opioid addiction. And what they said was overwhelmingly it was prescribed to white patients and rarely prescribed to patients of color. That's got to be a racist thing, right?
Yeah, absolutely. I think like any treatment, so buprenorphine, like methadone and some others, it's a medication assisted treatment. Great. It's the best, it's the best treatment for an opioid use disorder, which is another crisis, right? Another epidemic that we have, are still in. And yet we know that, like all healthcare, treatment is usually, there's going to be disparities in who has access to that treatment. This can be at the individual level where, a physician or, somebody just feels that, oh, well, you're not going to use it anyways, or you can't afford it, or you're not going to show up and, to get it when you need to get it anyway. So why am I going to bother? Or you're just going to be back in the ER again, so there's no point, to, not, or just them not having access, not having insurance to cover it, not having the financial means to cover it. We work closely here with a methadone clinic here in Spokane, and I work with perinatal women that have an opioid use disorder, and they're trying to get treatment. And some of the stories that we hear from the women here is, really just the transportation, needing to ride the bus with a newborn baby to stay on methadone every day, or going to the emergency room, telling them I'm on heroin, but I'm pregnant and I need a bed. And them having to say, we don't have a bed for you here locally because we have decreased resources here in Eastern Washington. So there's no bed available. So they're back on the street, and they're pregnant using heroin. We're really in a dire situation when it comes to health disparities, gender inequities, and then racial and ethnic inequities with the opioid use disorder. I don't think a lot of people know that really women are hit even harder. The time to a really severe disorder is a lot quicker than men, and access to treatment. Research is usually done with men. Research is usually done with white people. I mean, it's embedded in everything. So of course it trickles down to the one-on-one, situations as well.
It's a tough time to be a woman.
Yeah.
It is. I mean,
it is. I'm laughing only because if I don't laugh, I'll cry.
Yeah, I was gonna say.
Yeah,
It's that bad. Unfortunately, it is mind-boggling to me at times. I'm curious. This is so much. It just seems every day we've got some other thing that happens that is going to create some issue and add to the inequities in our country. How do you keep the spirits up of the students that hope to be the next, nurses and doctors and at the Elson Floyd School, and also hope to one day serve in the community, either rural community or elsewhere? That seems to me to be a tremendous challenge right now.
A challenge, and I think there's no better sales pitch than telling folks, especially our students of color, we need you. We need you to be that nurse. We need you to be that physician. We need you to be that faculty member in front of the room saying, yeah, I look like me and I'm a professor. I'm a leader in academia. We need that more than ever. We need them representing all of our residents of the state of Washington. We need that representation in healthcare, in higher ed, in leadership, in every, in every business. We need folks like the three of us, right? Doing what you're doing, because we know that the more, diverse organization and things like that, the more people are going to feel comfortable coming to you. We have some great clinics that are focused on communities of color in our state. And it gives me so much hope. It fills my heart with hope when I see the really intentional organizations that are really focused on serving communities of color in the right way and being embedded in those communities and utilizing the community voice to build their clinics and really serve that community in that way.
Yeah, that's, it's important to not let this be swept under the rug, but to actually bring it out and to talk about it like we're doing, because it is very much impacting of us all of us really, and not just the communities of color, but ultimately everybody in America. So we have to deal with all of that. Well, Celestina Barbosa-Leiker, thank you so much for joining us. We appreciate it, and hope to talk to you more in the future about these issues. All right.
Yeah, thank you so much. Thanks for having me on.